Hello friends and welcome to the edition of King's Crux, and today we will discuss a very important topic, that is acute red eye. I'm going to take this topic via a mind map which you can download for free from the description box below. It's going to be a PDF. So please download that PDF onto your phones or onto your tablets and have them handy as I am taking this mind map topic branch by branch or step by step. So by the end of this class, you should be able to diagnose a patient with acute red eye, and you should be able to give them the appropriate referrals or treatment accordingly. Now, this is not a standalone lecture on all the conditions causing the acute red eye, but rather I'm going to give you simple, important tips and tricks to pick up these conditions in your daily practice and make sure that you give them the right treatment and refer them appropriately. So without any further delay, let's jump into our mind map based teaching. As you can see here, this is going to be the mind map which you will be having or reading through on your phone or in your laptop, no matter what it is. Now, this is going to be a huge mind map, a mind map which has not just the text, but also images incorporated into them. All right, so it makes much more easier, much more illustrative, and far more effective in remembering these concepts. Okay. Now, you can download this PDF from the link given in the description box below on this video. Now, if you're going to have this mind map with you, you can access this lecture, what you're watching right now, by clicking on this link. It goes to the lecture, this lecture. This has lots of branches. You can see there are lots of aspects in this PDF. I'm just going to condense everything together. Okay, I'm just going to fold all the branches. So now what you'll be seeing here, you'll just see the bare bones or bare skeleton. I'm just going to expand. I'm just going to go from this centrifugal approach. I'm going to start from the basic, start from the core of this mind map, expand it further. All right. Look at this, please. Acute red eye is going to be an important condition which we will come across day in and day out. The best way to classify this is going to be acute red eye with defective vision and without defective vision. All right. I will take it one by one. First, we'll focus on with defective vision. Why this is important is because in your clinic, if you see a patient with an acute red eye and a defective vision, which means that is more important, okay, and it could be possibly vision threatening when compared to the conditions which cause acute red eye without defective vision. Okay, what are the conditions which causes acute red eye with defective vision? Easily put, acute keratitis, acute angle closure glaucoma, acute anterior uveitis, and acute endophthalmitis. And last but not the least, the injuries, namely your chemical injury and the mechanical injury. So please have these in mind. We will go one by one. Again, I just want to tell you that I'm not going to explain everything in detail. I'm just going to give the signs and symptoms of each so that you are getting it straight. Okay. So acute keratitis means there is going to be an inflammation of the cornea. Okay. Acute angle closure glaucoma, there's going to be increased intraocular pressure because of the AC, or the angles are getting closed. Thereby, it is impeding the outflow of the aqueous humor, thereby causing a sudden onset increase in IOP. Acute anterior uveitis, which means there's going to be intense inflammation in the anterior chamber, causing lots of problems. Endophthalmitis means inflammation of the inner coats of the eyeball. It's much more vision threatening than the other conditions actually. And injuries, you have mechanical injuries, which means there can be a trauma because of a blunt force or a sharp force. Then we have the chemical injuries, either alkali or acid burns. So if you can see, there is going to be one common denominator in all these things. In some way or the other, either cornea is involved or you have an impact on the media clarity. Because of these two reasons, there's going to be a defective vision. Okay. So coming back to the acute keratitis, the symptoms and signs. You will have pain, redness, grittiness, discharge. This discharge is going to be very important. Okay, glare, discharge because it's mostly infection, so you have this purulent discharge coming out. Glare because the cornea is involved. So the cornea has been getting involved. What happens? It exposes the corneal nerves are getting exposed to the sun or the normal light, therefore causing photophobia, which is a painful sensitivity to light. And obviously, you have defective vision because cornea is involved. So what history you will ask in these patients? Quickly, it's important to elicit the history of contact lens wear, which is very important. In a developing country like India, the important history to ask is going to be history of trauma with organic matter, which causes fungal ulcers, so fungal keratitis. In developed countries, you have to ask history of contact lens wear, especially patients who have worn their contact lens and they have slept without removing them. The next day morning, they find themselves having an acute red eye with defective vision, watering because of the contact lens induced keratitis, what is CLIC, contact lens induced keratitis. Please be aware of that. All right. Always elicit the history of swimming while wearing contact lenses or any history of contamination of contact lenses. These two are very important. Contact lens wear or contact lens induced keratitis can be because of two important infectious organisms. One is Pseudomonas, second is Acanthamoeba, which is a protozoa. Pseudomonas is going to be a bacteria. Having finished the symptoms and history involved with acute keratitis, let's move on to the signs involved here. What are the signs? The patient will have a ciliary congestion. Note the ciliary congestion is different from a diffuse congestion, what you will see in an acute conjunctivitis. This is a circumcorneal or a ciliary congestion, which means the ciliary vessels are involved. In conjunctival congestion, is going to be more of a diffuse congestion. The conjunctival vessels are going to be involved. Okay. Presence of an infiltrate or a corneal ulcer is going to be the sign in an acute keratitis, which is very obvious. The more important is if you're going to see a hypopyon, that indicates a more of a deeper infection. Okay, it's not just a superficial infection, more of a deeper infection. So patients can present with hypopyon, which is very important. The patient may have an anterior chamber reaction as well. And more importantly, in viral keratitis, in herpes simplex or herpes zoster infections, there's going to be loss of corneal sensations. So with this basic idea about acute keratitis, I'm going to go for the next differential diagnosis of a patient with acute red eye and defective vision. That's going to be acute angle closure glaucoma. Very important, very important. Because in keratitis, you will have an obvious answer right before your eyes. You will see a corneal lesion, but in acute angle closure glaucoma, you will not see anything on the cornea. You will just see a corneal haze. We'll come to that in a moment. Now let's look at the symptoms. Now, apart from this acute red eye presentation, the patient will have severe pain. And more importantly, the pain which makes you sick, the pain which makes the patient go crazy, they kind of vomit. So vomiting is an important history to be asked in a patient with acute angle closure glaucoma. Defective vision because of the corneal edema, corneal haze. Colored halos is a very important history to be asked, which is very unique to angle closure glaucoma in our scenario. It's quite unique in an acute red eye patient with colored halos. Think of an angle closure attack. All right. Look at the signs. What are signs you will see in this patient? And an obvious increase in IOP. This increase in IOP is not just a nominal increase; it's going to be a very high increase in IOP. 50 to 80 mm will be the amount of the rise in IOP. Ciliary congestion, like your keratitis. Epithelial edema or corneal edema, which can even go to the stroma, but it's mostly you'll see an epithelial edema in these patients. So microcystic epithelial edema. A shallow anterior chamber depth is very important, and you should also check the other eyes as well. That's very crucial, very important point for any resident out there. So you see an angle closure glaucoma, look for the other eye, look for any signs of risk factors for angle closure attack. More importantly, smaller eyeballs, or in case of high plus power or hypermetropia. All right. Now, there are three important signs which you will see in a patient who have had a previous angle closure attack, which you may see in a current or recent attack as well. A previous angle closure attack means you have three important signs, what you call as a Vogt's triad. You will have a fixed semi-dilated pupil, which you can even have in the current angle closure attack as well. Because of sphincter ischemia, there's going to be this fixed semi-dilated pupil. Patches of iris atrophy, again, because of iris getting affected because of the ischemia. And you can have subcapsular opacities, which are secondary to this lens epithelial necrosis, what you call as a glaucoma flecken. Very important. Like I said, these three are going to form this Vogt's triad. Always look for the other eye. Look for shallow AC, shallow anterior chamber depth. Look for smaller eyeballs or high hypermetropias. Plus, because of axial hypermetropia, the eyeball is going to become small, smaller eyeballs, crowded anterior chambers, more risk for angle closure. What I'm going to talk now is going to be about what I was talking is about the primary angle closure. Now we're going to talk about the secondary angle closure, which means there's going to be a secondary cause which is causing the angle closure. It's going to be most commonly will be a lens induced in mature cataracts, very dense cataract. The cataract is going to bulge, causing an angle closure, what you call as a lens induced, or here in our case, a phacomorphic glaucoma. Okay, very important. Now, coming to the other important differential diagnosis for acute red eye with defective vision, we have the acute anterior uveitis. What are the symptoms you will ask in these patients? The patients will have pain, redness, watering. There's going to be defective vision, which is plus or minus. Sometimes you may see patients with less defective vision as well. Okay, but for all practical purposes, consider uveitis and acute red eye with defective vision. Okay, glare. Glare is an important symptom. It's a symptom not just we saw in case of uveitis, but we also saw in keratitis as well. So any involvement of cornea, exposure of corneal nerves, or an intense AC reaction, antechamber reaction, inflammation, you can expect glare. The key point about uveitis is that always elicit systemic history. Always look for systemic signs. Systemic history includes history of joint aches, back pains, oral ulcers, any past history of tuberculosis, history of genital ulcers, history of any contact with pets at home. Okay, there's a big spectrum of history you should elicit to diagnose uveitis patients' systemic association. The key feature is history of recurrent episodes, which you will not see in many other conditions. A patient with acute red eye coming with recurrent episodes of this acute red eye, think of uveitis. Okay. Signs. The ocular signs. What are the ocular signs you will see? You have to look for these things. Very important. Always look for ciliary congestion. What are other conditions which you saw? We had ciliary congestion. You had ciliary congestion. You will see here. You will see in case of your acute glaucoma. You will see in acute keratitis as well. So ciliary congestion is a deeper congestion. Keratic precipitates, nothing but inflammatory aggregates settled on the back of cornea or on the endothelium. Keratic precipitates, which can be of two types, granulomatous and non-granulomatous. Depending upon what type of keratic precipitates they are, you can even make a diagnosis of the condition, what is causing the uveitis. Always assess and look for anterior chamber reaction. Look for cells and flare. So AC cells are nothing but these small, tiny dots, as you can see on this picture. That's called anterior chamber cells, nothing but the WBCs. Flare is going to be the smoky appearance, the smoke or the fog there. Okay, it's called flare. Flare happens because of protein leak. So in the anterior chamber, always look for AC cells and flare and grade them. Very important. When you have intense reaction, high amount of flare, high amount of cells, more of inflammation happening in the anterior chamber, what happens? The inflammatory cells are going to form a coagulum, is going to form a membrane and adhere to the pupil called as a fibrinous membrane. Look for them as well in a very severe or high-grade inflammation. Sometimes inflammation will be so much that they may settle down to the anterior chamber, forming a hypopyon. Now, we saw hypopyon in corneal ulcers or keratitis as well. You will also see hypopyon in uveitis also. Uveitis with hypopyon is going to be a very important thing to consider because very few diagnoses are there for uveitis with hypopyon. One is going to be Behçet's disease. Second is going to be HLA, B27 associated ankylosing spondylitis or seronegative spondylitis. Now, this is going to cause this very intense acute AC reaction, which is strong enough to cause a hypopyon. And this hypopyon in these two conditions are going to be sterile hypopyon. They are not infective. They are basically happening because of intense inflammation. In Behçet's, you will see this mobile hypopyon. In HLA-B27, you will see an immobile fixed hypopyon because of fibrinous content. The other signs are going to be presence of posterior synechiae, which means a festooned pupil. Festooned pupil means like a flower-like pupil or a flower-shaped pupil, which you will see in these patients. Posterior synechiae means the iris goes and adheres back to the lens capsule, forming this posterior synechiae or adhesions between the iris and the lens capsule. Because of uveitis, there's intense inflammation is going to affect the lens as well, causing complicated cataracts. The important thing to consider is that whenever you see a patient who's having acute anterior uveitis, always examine the fundus. Look for signs of intermediate and posterior uveitis. That's why it's always important to dilate the patient and examine the fundus, because we might be looking at a pan uveitis involving the entire eye. Pan uveitis means the anterior part, the intermediate or the vitreous part, could be even with the retina as well. So pan uveitis, don't miss out. Always dilate and see if the media is clear. Else do a B scan to assess how the posterior media is or how the vitreous cavity is. All right. We discussed about this important ocular signs. Now, the systemic signs are again multiple. Like I said, patients, especially with HLA-B27 associated seronegative spondyloarthropathy, they can present this intense acute anterior uveitis. So ask for history of back pain. Also look how their posture is. Sometimes these patients can present with a back pain or spondylosis or spondylitis. Now we have finished this. We have finished acute anterior uveitis. Now coming to the next differential diagnosis for acute red eye with defective vision, that's going to be your acute endophthalmitis. Very important. Please pay attention to this because many doctors, ophthalmologists, surgeons, they are sued because patients end up with endophthalmitis after cataract surgery. Because essentially, during cataract surgery, if things go wrong, for example, if you're going to make a complication or not a sterile atmosphere is being maintained, infections can get into the eye, causing inflammation or infections because of involved in the inner coats of the eyeball, what you call as endophthalmitis. So endophthalmitis symptoms, ask for history of any recent cataract surgery. Not just that, always ask for history of any intravitreal injections. So it's not just your cataract surgeries. Anything which goes into the eye can lead to infections getting into the eye, leading on to endophthalmitis. Any history of ocular trauma, again, can cause. And systemic also, any history of long-standing intravenous lines, intravenous injections, look for any systemic sepsis. Pain, defective vision, redness will be the common complaints. And there's going to be a preceding floaters because of involvement of inflammation in the vitreous cavity, what you call as a vitritis, inflammation of vitreous. Okay. The signs involved are going to be similar to your acute anterior uveitis. Sometimes acute endophthalmitis can mimic like uveitis. Okay, so we have to be aware of that. Patients will have a ciliary congestion. They're going to have corneal edema, which you may not see in case of your uveitis, but edema you may see. Corneal edema will be very typical. Stromal edema, which will be very, very typical in case of your acute endophthalmitis. Keratic precipitates, which you already saw in case of your uveitis as well. Hypopyon is a very important feature of acute endophthalmitis. Okay, so you see an intact cornea, which means there is no corneal breach, but you see hypopyon, think of uveitis and think of endophthalmitis. You see hypopyon, think of three: keratitis, uveitis, endophthalmitis. Okay. In the anterior chamber, you may see AC reaction, or you may see vitreous in the anterior chamber. Why vitreous in the anterior chamber? Because during cataract surgery, we might have breached, we might have opened up the posterior capsule, which leads to vitreous coming out from the vitreous cavity all the way into the anterior chamber. All right, it's very important. And that's why it's very important to assess the lens status of the patient. Patients may be pseudophakic, and loss of PC posterior capsule, you should also look for that. And please do a B scan to look for vitritis. As you can see in this picture, in this B scan, it shows lots of this multiple small dot-like hyperechoic opacities there, dot echos, which means that there can be inflammation of the vitreous cavity, what you call as vitritis. So far clear? Okay, this is an important aspect. I'm dealing with these conditions in a much more detailed way because these are all emergencies. Okay, these are all emergencies. These are all can be sight-threatening in many ways, sometimes even life-threatening. Okay. Now let's speak of the injuries. As far as injuries are concerned, can be either because of a mechanical trauma or can be because of chemical injury. Mechanical trauma can be either because of a sharp instrument or can be because of blunt instrument. So you can have a sharp trauma or you can have a blunt trauma. This is an important classification which every resident should know. It's called as a Birmingham eye trauma terminology system, which gives a very neat classification of how to classify, how to differentiate these ocular injuries caused by mechanical trauma into closed globe or an open globe injury. A closed globe injury means there is no breach of the ocular integrity or the ocular surface. An open globe means the globe is basically open. The closed globe can be either a contusion or it can be a lamellar laceration, whereas an open globe will be either a laceration or a rupture. A contusion and rupture are basically caused because of a blunt injury. The others can be caused because of penetrating trauma. Laceration can again be classified into penetrating injury or perforating injury or intraocular foreign body. All right. So these three are going to be very important as far as laceration is concerned. Now that's with the mechanical trauma. So moving on to the chemical injuries, which means there can be either acid or alkali injuries. Always note that the alkali are more destructive when compared to acid. That's important to understand. As far as signs are concerned, though I have classified this chemical injuries as a part of this acute red eye with defective vision, white eye can also be seen in very severe burns because of the intense reaction, intense burns. There can be ischemia, and this ischemia can cause blanching of the conjunctival vessels, blanching of the perilimbal vessels, leading on to this suspicious white eye. So this white eye indicates a severe degree, indicates ischemia. All right. Having that in mind, always examine for lid burns, look for any retained alkali particles or any lime particles in the fornices, lower fornis, upper fornis, always evert and look for these particles which can constantly release alkali, leading on to destruction of the ocular surface. Conjunctival chemosis. The patient can have conjunctival chemosis, they can have congestion, they can have conjunctival burns, scarring as well. Cornea, you have corneal edema, epitheliopathy. It can be very severe enough to even cause a stromal necrosis, and also look for AC reaction in these patients as well. So now, having completed the injuries, the mechanical and the chemical injuries, let's quickly go on to the next half of the topic, that is acute red eye presenting with no defective vision. Okay, so we finished with the defective vision. Now we're going to without defective vision. So in the without defective vision, there can be these conditions which can cause an acute red eye without defective vision, namely acute conjunctivitis, allergic conjunctivitis, episcleritis, anterior scleritis, subconjunctival hemorrhage, foreign body of the conjunctiva or cornea, and finally the epithelial defect of cornea. So please note that now all these conditions need not always present without any defective vision. There can be an associated blurring of vision being a part of this, especially when they're going to involve the cornea, when they're going to involve some part of the visual pathway from the cornea till the cortex, can happen anywhere, and they can cause defective vision. Let's talk about a more important is going to be acute conjunctivitis. And they present with symptoms such as a discharge or stickiness, redness, irritation, pain may or may not be there. Like I said, only if cornea is going to get involved. In case of keratoconjunctivitis, the patient can have a defective vision. History of a generalized illness or a spread among family, contagiousness, because these acute infective conjunctivitis, especially viral infection, can spread by sharing of common objects like fomites, sharing of towels. So they can have this spread in the family. Sexual history is very important. Now let's spend a minute on this. Understand a patient, an adult patient coming to you with acute conjunctivitis, and if you're going to suspect chlamydia or gonococcal, always ask for a sexual history, because these two are going to be sexually transmitted diseases. All right, that's number one. What is even more important is that when a mother who's affected with chlamydia or gonococcal infections, she can transmit the infections to the baby, to the neonate, while giving out the baby. The infections can be transferred from the vaginal wall to the eye, leading on to an infective conjunctivitis, an acute infective conjunctivitis, happening in newborn less than 4 weeks of age. What do you call it as? Ophthalmia neonatorum. Okay, and chlamydia and gonorrhea are going to be two important implicating factors of ophthalmia neonatorum, of which chlamydia is the most common cause. All right. So with that in mind, let's look at the signs involved. The signs, basically, the patients can have adnexal signs, which is very important to look. Most often we tend to miss these adnexal signs, especially always look for blepharitis. Look for this blepharoconjunctivitis, especially in cases of herpes simplex viral infection. The patients can initially present with just blepharitis and then becoming blepharoconjunctivitis. Look for lid edema. A lid edema is quite common in acute infective conjunctivitis as well. Discharge. This discharge is very important because depending upon the type of discharge, you can even find what the type of infection is. The discharge can be either of three types. One is a watery discharge, a mucopurulent discharge, or a purulent discharge. Watery discharge is what you most commonly see in adenoviral infections. The most common cause of infective conjunctivitis is going to be viral, and most common virus is going to be adenoviral. Mucopurulent is more commonly seen in chlamydial infections. Purulent is seen in the bacterial infections, and more importantly, the gonococcal infections. This can present this hyperacute, severe purulent in neonates, what you call as ophthalmia neonatorum. All right, with that in mind, let's go to the other signs here. The diffuse condition is one thing. We said that this is different from the ciliary condition, what you see in keratitis or uveitis. This is more of a diffuse condition, superficial condition, which most often you see in the lower palpebral conjunctiva, versus a ciliary condition is what you will see surrounding the limbus. So the other name for this circumcorneal congestion or perilimbal injection are the names given for the ciliary congestion. This is more of a diffuse condition in conjunctivitis. The patient can have chemosis or conjunctival edema. The patients can have follicles. Follicles are these grainy rice grain-like particles, rice grain-like lesions which are seen on the lower palpebral conjunctiva. They're nothing but lymphoid aggregates. These lymphoid aggregates are important because in a baby, in a neonate who's going to have a viral infection, viral conjunctivitis, the baby will not have any follicles because there's going to be a delayed development of lymphoid tissue. That's why you will not see follicles in neonatal conjunctivitis. It's an important thing. Instead, they will be having papillae. So papillae can be present in bacterial conjunctivitis. Sometimes the discharge can be severe enough to form a membrane called the pseudomembranes and conjunctiva. Always differentiate this from the true membrane, what we see in diphtheria. Like I said, presence of infection within the conjunctiva, no defective vision. But if the involvement is going to go to the cornea, that becomes a defective vision in case of this adenoviral keratoconjunctivitis, where you can see these multiple small white dots on the cornea. They're called as superficial punctate keratitis or subepithelial keratitis. Now, these things can cause blurring of vision. Preauricular lymphadenopathy is going to be another important sign to elicit in viral conjunctivitis. We have finished the acute infective conjunctivitis. Now let's move on to a very underrated area. It's the allergic conjunctivitis. Always think of allergic conjunctivitis. They may not always present an acute red eye, but they can be a chronic redness. Patient most often has hitching. They will have this watery or sticky discharge with history of allergy, atopy, asthma, or any seasonal occurrence. As far as signs are concerned, always look for this watery or mucoid ropey discharge, like a sticky ropey discharge. The patient typically tell in the morning. Presence of papillae. We saw that papillae was also found in bacterial conjunctivitis, but papillae is more specific for allergic conjunctivitis, and most often they are seen in the upper tarsal conjunctiva. And these papillae can become like a big blocks, what we call cobblestone papillae in case of your vernal keratoconjunctivitis. Very important. Again, you can see chemosis or ballooning of conjunctiva. The patient can have punctate epithelial erosions on the cornea, so always stain these patients. In vernal keratoconjunctivitis, you will see patients having these very, very typical signs called as the limbal papillae, Horner Tranter spots, and vernal ulcer of the cornea as well, where you'll have a defective vision. Now, these patients constantly rub their eyes because of allergy that can lead to this conical deformation of cornea, what we call as a keratoconus. So look for signs of keratoconus, which happens because of constant rubbing in patients with or allergic conjunctivitis. All right. Episcleritis is going to be one of the, again, important causes for acute red eye without defective vision, which is quite common, especially in young to middle-aged females with history of recurrence. So patients often present with this redness with or without pain, which is frequently occurring. Episodic occurrences are quite characteristic of episcleritis. Signs, the patient will have a sectoral condition. This is not like a complete condition. It's more of like a sector. Only one quadrant is being involved. It can either happen in nasal or the temporal quadrants or areas can be involved. The patient may or may not have a nodule over the condition. This is where it's important to differentiate this from a pincicula, which is inflamed, called inflamed pincicula or pingiculitis, or an inflamed early pterygium. So always have that in mind. On the contrary, anterior scleritis might look like episcleritis in some aspect, but they are much more deep-seated, they're much more ominous, much more dangerous because they can be vision-threatening, they can be even life-threatening as well. So anterscleritis means that you have a posterior scleritis as well, but posterior scleritis, you will not see redness. Anterscleritis, you will see redness. The symptoms are very typical. The patient will have pain. The pain is going to be a very important symptom in scleritis because the pain is going to be very severe. In fact, they'll say the scleritis patients will scream. Okay, redness, defective vision if cornea is going to get involved, only if it is involved, if not, no. Or if it's going to be a posterior scleritis can also cause a defective vision. Systemic involvement. The most common cause of scleritis or anterior scleritis is going to be a rheumatoid arthritis. So always look for this condition. Always ask history of rheumatoid arthritis, history of any joint pain. As you can see in this mind map, I have given multiple red boxes. These red boxes indicate the important clinical take-home messages, all right? Now let's look at the signs. As far as signs are concerned, the patient can either have a sectoral or a complete condition. In fact, it is important to note that it can highly mimic like an episcleritis, or sometimes the patient can have like a uveitis, like you have a complete condition as well. The key point is that sometimes the patient can have a nodule over this condition. And this condition is quite characteristic because this condition is not your usual condition, what you will see in episcleritis. They have this violaceous hue, which means more of like a violet-like color you will see, especially under daylight. You will have a scleral edema. And most importantly, this condition will not blanch when you instill a vasoconstrictor like phenylephrine. Whereas in episcleritis, on instillation of phenylephrine, there will be blanching of blood vessels. A very important differentiating feature between episcleritis and scleritis because the treatment totally differ. All right. So this nodule overcongestion is another important characteristic feature of a nodular scleritis, what you call one of the subtypes of scleritis. As days progress, what happens? The scleral inflammation can kind of thinned out what you call scleromalacia, that can lead on to this exposure, this bluish hue, which is being shown there, nothing but the uveal tissue shining through the thin sclera. Sometimes they can even perforate, because scleromalacia perforans is a very important complication of scleritis. If you see a pus pointing over the nodule, please think of scleral abscess, which is most commonly seen in infective scleritis. Okay, very important. History of trauma can lead on to scleral abscess, so think of infective scleritis. Also note that, like I said earlier, involvement of cornea in scleritis can cause defective vision, what you call sclerokeratitis. Sometimes the posterior sclera can also be involved, what's called what you call a posterior scleritis. In that case, there's going to be inflammatory fluid which is getting collected in the subtenon space. So on B scan, you will see the so-called T sign, the collection of the fluid in the subtenon space, along with the optic nerve head shadow, which gives like a T, which looks like a T. So it's called characteristic T sign, what you will see in case of your posterior scleritis. So always do a B scan when you suspect one. Now let's move on to subconjunctival hemorrhage. It's a very common presentation. Many patients, especially elderly patients, they often come to. Subconjunctival hemorrhage, or SCH, is going to have two extremes. Sometimes it can be very trivial trauma, or the patient can have bleeding disorders, or they can have very high hypertension. So ask for history of trauma, history of rubbing, high blood pressure, bleeding disorders, or Valsalva maneuver, such as exertions, too much of coughing, too much of strain. Always check blood pressure in these patients who present with SCH in your clinic. The signs can be simple redness, but you can have associated signs of ocular trauma as well. Please understand, this is not going to be a congestion. A congestion is more of a dilatation of the blood vessels. This is more of like a hemorrhage, breaking of blood vessels leading on to diffuse hemorrhage. So this is a confluent hemorrhage, which can be either sectoral or can be complete. The other signs of blunt trauma, blunt ocular trauma, which happens, which can cause this SCH, are going to be these. Always look for any adnexal signs. Look for periorbital ecchymosis. A fracture of the floor of orbit can lead on to entry of air under subcutaneous tissue called as the emphysema, subcutaneous emphysema, which leads to Keratitis. There can be involvement of the nerves causing the cheek anesthesia. And because of the entrapment of the inferior rectus muscle, can lead on to restriction of elevation, leading on to diplopia in these patients as well. So this is the signs of blowout fracture or fracture of the floor of orbit. Always look for any occult or hidden conjunctival tear or corneal tear, because with this hemorrhage, it may be very easy to miss out on any occult or hidden conjunctival or corneal tears. Look for hyphemas, which may or may not be there. Pupil signs. Patient can have a relative afferent pupillary defect if there's going to be a traumatic optic neuropathy associated. The patient can have a traumatic mydriasis if there's going to be a sphincter tear associated. Look for any lens dislocation or cataract, and look for fundus signs. Fundus signs can be multiple, but more importantly is that the patient can have a Berlin's edema or a commercial retina, nothing but the edema of the retina in case of a blunt trauma, which is transient. And always look for presence of cherry red spot if macula is going to get involved in this condition. Okay. The second important sign is going to be presence of retinal dialysis, where the retina is going to get detached from the ora serrata. There's not retinal detachment, this is a retinal dialysis. There's a detachment from the ora serrata. Okay. Which means that in any patient who comes with you with subconjunctival hemorrhage, when you suspect trauma history, always dilate these patients and see. Now, moving on to foreign body of conjunctiva and foreign body of cornea. Foreign body of conjunctiva is very common. Again, always ask history of any exposure to foreign body while driving a two-wheeler. There may be some insect getting into the eye. The patient can present grittiness or irritation. There can be pain. Signs, you can see an obvious foreign body on the conjunctiva, or you may not find a conjunctival foreign body unless you evert the lid and see, where you will see an upper tarsal conjunctival foreign body. Now, this foreign body, what happens as the patient closes and opens the lid, it can kind of paint the cornea, leading on to this patterned abrasions, like a brush paint like abrasions, which you will see on the cornea after fluorescent staining. So you see this picture, which means that there can be a hidden or a missed foreign body on the upper tarsal conjunctiva. This is called the ice rink sign. Very important. Foreign body of cornea. The patient again can present with typical history of grittiness, pain, redness, watering, and glare. Why glare? Because cornea is getting involved there, all right? So patient with history of welding, exposure to metallic foreign bodies. As far as the foreign body on cornea is concerned, always make sure that you are not missing out any secondary infection or infiltrates. You're not missing out any perforations or any kind of a possible penetrating ocular trauma or even intraocular foreign body. Always be aware of that. Finally, we talk about the epithelial defect of the cornea. Epithelial defect of cornea, again, can be quite common in patients, especially with history of rubbing, history of contact lens wear is, again, an important history to ask in these patients. The patients can have pain, redness, watering, or glare. Okay, glare, again, why? Because cornea is getting involved. The signs are going to be, again, multiple. The patients can have congestion, ciliary congestion. They can have this epithelial defect. And after staining of the cornea with fluorescent, only then we will detect the epithelial defect. Always mention the size of the epithelial defect. Check for foreign body on the cornea. Check for dry eye disease. And check for any condition which can cause a recurrent corneal erosions, other conditions which can cause a persistent epithelial defect. All right. So now what we've done is we have completed the two areas. We've completed the details of acute red eye, which can cause defective vision, the other cause of acute red eye without defective vision. Now we have done the differential diagnosis of each in detail. Now let's summarize. I know it's like too much information for you guys right now, but please bear with me. This is an important area. The summary will kind of nail the diagnosis, will make your concepts more concrete and easy to remember. First is that an acute red eye patient can have without defective vision and with defective vision. Now, you know what are the causes for both in detail. Okay. Secondly, is going to be what are the conditions which can cause acute red eye with discharge. You can either have acute conjunctivitis, allergic conjunctivitis, or acute keratitis. All these three things can cause an acute red eye with discharge. Okay. Now, the acute red eye based on congestion, based on what type of congestion is being involved. I said we have either sectoral congestion, diffuse congestion, or ciliary congestion. Sectoral means one part of the area is getting involved. What are the conditions? You have episcleritis, you have scleritis, and you have inflamed pterygium or pinguculitis. Being the differential features of sectoral congestion with or without a nodule. You can also have a sectoral hemorrhage in subconjunctival hemorrhage. Okay, remember that as well. Diffuse congestion is typical of an acute conjunctivitis, whereas you will see ciliary congestion in more deeper involvement like acute keratitis, uveitis, ankylosing glaucoma, and case of scleritis. There are a few other important algorithms also. Acute red eye with glare. You will see acute red eye with glare in case of uveitis, keratitis, and foreign body. When you have an involvement of cornea or when you have an intense AC reaction, patient can have glare or photophobia, which is nothing but the painful sensitivity to light. Acute red eye with systemic association and recurrent episodes, very characteristic in cases of uveitis, scleritis, and viral keratitis. Even viral keratitis, especially in herpes zoster infections, the patients can have systemic involvement. They can be in immunosuppression can be there. They can have recurrent episodes in viral keratitis as well. Acute red eye with hypopyon is another important feature where you will see them. You will see in uveitis, the sterile hypopyon. You will see in acute keratitis or corneal ulcer. You will also see in acute endophthalmitis as well. Finally, I'm going to talk about an important aspect which I have not dealt much, but this is crucial because when you see a bilateral acute red eye with proptosis, with extraocular movement restriction, think of something more serious, something more life-threatening. Okay. So in these patients, especially patients who have an active thyroid eye disease, where it's going to be chemosis, there's going to be congestion is going to be there, and the patient can have proptosis with extraocular muscle restriction. Cavernous sinus thrombosis, again, proptosis, chemosis, extraocular muscle restriction. Keratico-cavernous fistula, think of CCF in patients who have this corkscrew vessels, which is very characteristic of keratico-cavernous fistula, corkscrew vessels. In case of orbital cellulitis, the most common cause of orbital cellulitis in children is going to be ethmoidal sinusitis. Always look for the foci of infection in orbital cellulitis. It can be even a simple style leading on to a preceptor cellulitis, then going for an orbital cellulitis. Orbital trauma, like we discussed some time back, look for the signs. So the key point is whenever you look at this acute red eye in orbital or adnexal pathologies with extraocular movement restriction, please look for the pupillary reflexes, look for RAPD to rule out any optic neuropathy associated with it. So now I've completed this video review on this mind map. Now this might be a standalone lecture for you. So please watch this lecture and please watch this while you're reading the mind map, and please review this lecture as and when you want. This is going to be a complete comprehensive take on this. So thank you so much for your patient listening. Hope you enjoy this effort. Thanks a lot. Take care. Bye.